Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by Novartis, Allergan, Janssen, Biogen, AGTC, MeiraGTx, and the SickKids Foundation. We'd also like to thank Accessible Media Inc., our national accessibility partner. Everyone should download the AMI app, which is a fabulous resource, and you can watch excellent programming, including previous Fighting Blindness Canada events. Thank you for watching. We hope you enjoyed this webinar and share your thoughts with us in the comment section below.
And welcome, Dr. Choudhry. So I'm just going to dive right into it with hopefully sort of a beginner question about how does diabetes affect the eye? So we'll just start at the beginning.
So thanks, Larissa. Thanks, Morgan, and thanks to the Foundation for inviting me to present this information to all of our patients and listeners. So diabetes, we all know this disease for a long time, and diabetes really is a disease of high blood sugar and trying to tolerate and manage blood sugar. Diabetes tends to affect blood vessels all throughout the body. The eyes are not the exception. Of course, in the body, the smallest blood vessels are in the eye. And over time, through the blood sugar exposure and high blood sugars, they damage blood vessels. And so what happens is as the blood vessels become damaged over time, they begin to leak what's inside them. And so diabetic retinopathy basically is a disease of leakage of blood vessels due to high sugar. And the blood vessels, once they become damaged, they leak what's inside them, which is blood, fluid, and cholesterol. And when that starts to leak and present itself within the back of the eye, in the area called the retina, it's termed diabetic retinopathy.
Thank you. And actually, so I've heard about diabetic retinopathy, but we also talk a lot about diabetic macular edema. Can you explain how they're both different, or are they similar diseases?
Yeah, sure. So, diabetic retinopathy is the broader category of the condition. And diabetic macular edema, if you just break it up into its terms, it's quite simple to understand. So we think of the retina like a dartboard, okay? So the entire dartboard is the retina, and the central bullseye, the 100-point score in the center, is the macula. So diabetic macular edema refers to swelling or increase in fluid in the center of that dartboard, in the center of the retina, in the macula. And so as I mentioned earlier, as the vessels begin to leak, fluid and blood and cholesterol can begin to collect within the retina and also concentrate itself within the center of the retina and the macula, which again is what we call diabetic macular edema. Why is this important? It's really important because what we know from our studies is that once diabetes begins to affect the eye and diabetic macular edema sets in, there's an increasing risk year over year of severe irreversible vision loss. So when a patient hits that point, or a person's eye hits the point of having diabetic macular edema, we're very cognizant of this and we want to be aggressive in treating it should it meet the treatment criteria.
So just so I'm clear, so can you get diabetic macular edema if you haven't already had diabetic retinopathy, or is it always a progression from retinopathy to macular edema?
Great question. So in order to have diabetic macular edema, by definition, you already have diabetic retinopathy. So diabetic retinopathy comes in various stages. You can have diabetes and have no retinopathy, which is the ideal situation, really. But over time, there are different stages, and the stages are mild, moderate, severe diabetic retinopathy. At any of those stages, you can start to develop diabetic macular edema. After severe, there's very severe, then there's proliferative, there's very proliferative, and then in some cases, patients end up having surgery. So there's a big continuum from not having any retinopathy and having diabetes to being in surgery to try to repair a possible diabetic-related retinal detachment.
Okay, thank you. So we've talked a lot about sort of retinopathy and macular edema. Are there other types of vision loss that can also affect people who have diabetes, or is retinopathy the main one?
So there are definitely other forms of vision loss that come from having had diabetes. We can definitely touch on all of them. Diabetic retinopathy is one of the more commonly known ones, but all of us have heard of the term cataracts, and cataracts refers to clouding of the natural lens of your eye. And all of us as we age will develop some degree of cataract, but diabetics tend to develop cataracts a little earlier, and also a specific type of cataract, which can often be much more visually debilitating. So cataracts are one of the things also that can be caused by diabetes. Glaucoma is another term that we've all heard of before. It's a condition whereby you can get optic nerve damage from either low, normal, or high pressure, and a few other side causes. But diabetes is also a risk factor for developing glaucoma, because all things require blood flow, and they require good blood flow. And with diabetes, blood flow in general throughout the entire body is not at its best. It's somewhat compromised. So all tissue structures are starved of oxygen that they would otherwise normally get if we did not have diabetes.
So is that also what causes the increased risk of cataracts, is the lack of blood flow?
So it's not, it's actually, in that case of cataract, it's not blood flow. There is a change to some of the biochemicals which are present in the back of the eye, which is believed to be the source of the exposure of the lens to forming a cataract. And so it's that elevated glucose and some of the changes of the biochemistry in the back of the eye, not exactly oxygen related, but it does contribute as part of multifactorial causes.
Okay. Yeah, so I read about cataracts and glaucoma, but I couldn't figure out why cataracts were higher in individuals who had diabetes. That's interesting. Thank you. So talking about all of these diseases, they're all relatively common, but do you have an idea, like, can you give us an idea of how common diabetic eye disease is, both diabetic retinopathy, but also
Sure.
some of these other ones as well?
Yeah, I mean, and so, you know, first thing we want to look at is how common is diabetes in Canada? You know, and some of the latest data that we have from the Canadian Diabetes Association shows that 1 in 3 Canadians of the 30 some odd million Canadians that are living in Canada, 1 in 3 have either diabetes or pre-diabetes. So that's almost 30% roughly of our entire population. And then when we break that down, diabetic retinopathy takes on average 10 years or so to manifest itself within the eye. And the average number of people that have diabetic retinopathy presently now is about 500,000 people. And that's the diagnosed group, right? So same with diabetes, it's based on just diagnosis. There are many people that are walking around with all sorts of conditions, diabetes included, that are likely undiagnosed. So this is just based on the data that we know. And I think if you're a diabetic, and whether you're recently diagnosed or you've been diagnosed in the past number of years, getting an eye exam annually in order to screen for diabetes or manage your diabetic retinopathy is imperative.
So obviously the eye exam, getting that regularly is really important, but are there other symptoms that somebody should look out for if they have diabetes? Or
yeah, sure. So, you know, one of the things I think we're really going to touch on is the fact that you can have no symptoms and have diabetic retinopathy. So as I mentioned, having a few spots of blood in the back of the eye may not manifest with any symptoms of any kind. You may still have great 20/20 vision. In some cases, we even see people with 20/20 vision and they have a little bit of diabetic macular edema. So while your vision could get blurry from diabetic retinopathy, it does not necessarily have to. So some symptoms can include blurry vision, loss of vision. Those are sort of general symptoms that someone might experience. But most importantly, you may have 0 symptoms and have diabetic retinopathy. Henceforth, a dilated exam once a year should really be done to screen for that.
And so you mentioned once a year. So is that the standard amount, or are there people who maybe can go less than once a year or should go more than once a year?
So this is really a great question. I think that the data, the guidelines are constantly evolving on this with respect to the Canadian landscape. I think, you know, in the crowd that we tend to see as retina specialists, we recommend at least once a year that an eye exam should be performed by an eye specialist, either an optometrist or an ophthalmologist or your retina specialist. And again, it depends also on the degree to which, how long you've had diabetes also, whether you go more frequently or less frequently.
Okay, so actually that gets to another question I had about what are some of the risk factors that play a role in driving diabetic eye disease? So the amount of time you've had diabetes seems to be one of them. Are there other ones?
Yeah, definitely. I mean, I think, diabetes is a vascular condition. It affects blood vessels. So a lot of the things that affect our blood flow are going to work and affect diabetes. So if you have hypertension or high blood pressure or high cholesterol, those things will work synergistically or work together with diabetes to make diabetes worse. So managing your blood pressure, managing your cholesterol, smoking, not something that we think about as regularly anymore, but some people still smoke. And thus far, no good has come from smoking yet. And smoking also can make diabetes worse in all parts of your body, including the eye. And obviously, being obese or being overweight or not exercising, all of these things kind of come together because being overweight or not having good blood sugar control is all aggravated by a sedentary lifestyle or smoking or hypertension. All of these are the big risk factors that we really want to try to control. It's sort of an easy saying in the clinic, what's good for your heart's good for your eye, right? So exercise, eating a heart healthy diet, green leafy vegetables, positive thinking, controlling your other conditions like hypertension, diabetes, all of those things work together to help us see and live.
Is there also any sort of genetic predisposition for, obviously for diabetes, but also for eye diseases? Or is it more of an environmental factor?
So yeah, that's a good point. I think there is a lot of data that there is a component of diabetes, obviously, that is inherited. It has been known and been published that certain ethnic and genetic subgroups are more prone to this than others. I mean, I can speak only from my perspective as a South Asian man. Our population tends to have smaller blood vessel size. And as a result of having a smaller blood vessel size, we're already getting a little bit more restricted blood flow to all parts of our body. So there is definitely a genetic component to it that needs to be considered, but we're not always tattooed with our genetics. And so therefore, as you said, Larissa, our lifestyle modifications can vastly change our overall trajectory towards developing or not developing a disease.
So you mentioned before the yearly eye exam that people should be getting. Can you maybe talk a little bit more about what that eye exam is? So how do you diagnose eye problems from diabetes? What would somebody do if they went to a clinic? What sort of test would they be getting?
So if you went to your local optometrist or ophthalmologist, or just we can even say eye care provider, you would want to have a dilated eye exam where you're given eye drops to make your pupils larger. Not always comfortable, but necessary in order to do a thorough job. And they may take photographs of your retina in order to document what they see. But looking into the eye that's dilated with a lens with light and a lens to examine all quadrants of the retina to the best of their ability would be a really comprehensive way of looking at the retina and the effects of possible diabetes. But as I mentioned, diabetes affects all aspects of the eye. So a front to back exam, including your vision, checking your pressure for glaucoma, and then of course dilating the eye, all of that would be significant constituting a full eye exam.
And would this be something that your family physician would tell you to do, or how would you go about booking this appointment?
So, our family doctors are very key. They're the gatekeepers of all of our healthcare, very critical, very important. So our family doctors, on average, most of the time, we should refer us to an eye care provider in order to get an eye exam if we're diabetic. But this type of webinar and information dissemination like this should prompt you to also, get an eye exam if you're a diabetic. You don't necessarily need to rely on one particular person to refer you, but it's the ideal way to get a diabetic eye exam is through a referral through your family doctor to an eye optometrist or an ophthalmologist.
Okay. And so hopefully everybody's going for their eye exams regularly, but if there is an emergency, what is sort of considered an eye emergency, whether it's for if you've got diabetes or if you don't have diabetes? So what should somebody do if they are seeing like sudden changes in their vision?
Yeah. So, that can be a scary situation, right? I mean, having a sudden change in your vision can be usually quite noticeable. It may or may not be from diabetes. It may be from some other issue. It could be an optic nerve problem. It could be a cataract problem. It could be a diabetic problem. So the thing to do, obviously, is, really try to get into an eye care provider. Sometimes we end up in the emergency room, which is, a good option. It may be more challenging these days, but if you're concerned about your vision and you've had a sudden change in vision, it would be the ideal move would be to see an eye care provider, either an optometrist or an ophthalmologist, or at the minimum, consult your family doctor so they can help to triage where you should go and what the extent of the problem is.
Okay. And moving on into talking about treatments, I know we talked about a bunch of different diabetic eye diseases, and maybe starting with diabetic retinopathy. Could you talk a little bit about the treatments that are available and how often somebody might get them, and what they do?
Right. So, as I mentioned earlier, diabetic retinopathy has multiple stages: mild, moderate, severe, very severe, and we go down the list. And currently, right now, treatment is focused on two main things. One is controlling your diabetes, right? So that's never going to change. Having better blood sugar control, exercising, eating healthy, not smoking, that's all treatment for your diabetes to better control blood sugar. So either you don't get diabetes, or if you have diabetic eye disease, that it improves. All of those things will also improve your diabetic retinopathy. If you have diabetic macular edema, which, as we said, was swelling in the center of the retina from blood and fluid and cholesterol leaking there, then if it meets a particular criteria, then that is something that we do treat as retina specialists and as ophthalmologists. And that involves giving medication to the eye as part of an injection. So the eye is anesthetized or numb, and then we give this medicine, and it's given at a frequency that's tailored to the individual, often once a month, until the fluid and the diabetes is improved. Sometimes we will use laser to also help us to seal the vessels. And nowadays that's considered second line therapy.
So in terms of, sorry, I just lost my train of thought there. So I guess one of my questions is, you mentioned about sort of COVID. Are people still able to go in and get their injections right now? Are they still going in once a month, or is it okay if people miss their appointments for like a month or two because they're at the risk of maybe getting infections?
Yeah, so that's a great question. I think we were really struggling with answering that question early on in the pandemic as we were just sort of trying to get our bearings. I think most medical clinics and treating clinics that are treating these conditions have put into place very good COVID precautions in order to keep their patients safe. None of us want anyone to go blind because of the pandemic, and even if there wasn't a pandemic. So the injections, for the most part, in my practice, for example, and I know from my colleagues around the city, they have resumed those treatments for their patients. Obviously, we're all doing our best to limit patient visits to only those that need to come in, like patients, for example, that need treatment. So I think the best thing to do in that course of action is, if you have a treating provider, to connect with their office, ensure that they're accepting to see you back for your treatment, that there are COVID precautions in place, which I suspect, of course, that there should be, and do your best not to sacrifice your vision during this time unless there's another factor that's holding you back.
I think that's a really important message to hear, because it's really unclear how often people should be going into, they should be staying at home and not getting treatments. It's really good to hear that you've got so many things in place to protect your patients.
Yeah.
At the beginning of that, your answer, you mentioned about reducing the progression. So if somebody starts to control their, say, blood sugar or their cholesterol, can their vision actually improve from doing some of these lifestyle changes?
Absolutely. Absolutely. So, the beauty of diabetic retinopathy is that there are a number of stages, and many of those stages can be reversed, can be downgraded. And we've actually seen this by giving injections to patients who are at one stage. By treating their macular edema, for example, they not only are successful in their macular edema resolving, but they get downgraded to a less threatening stage of diabetic retinopathy. So everything works synergistically. Your diet, your lifestyle, positive thinking, going to your appointments, getting your treatments, that 360 approach to tackling your condition as a systemic condition like diabetes, or even just a diabetic retinopathy, all of that works to help to recover and improve your vision. Of course, there are situations where the condition can progress so far that there is vision loss that is irreversible. And the point of this type of webinar and instructional information that we're trying to disseminate out is to not get to that point, is to get seen soon, get dealt with soon, and reverse everything that can be reversed.
I think you've given some really good words of advice here. Before we turn it over to questions from the audience. I was wondering if you have anything else that you can tell us about how to reduce the risk of diabetic eye disease or how to keep your eyes healthy.
I think one of the things that now we're all in a pandemic, that's where we are. We're all shut in, we're all at home, and our routines are all disrupted. I think the one thing that we can all really do to make a concerted effort towards our health is exercise. It's something that can fall by the wayside because you used to go to a gym, or you may not have been exercising before, but at home you can do a lot. And if it's accessible to you, or you can create an environment where you can exercise, that's going to be good for all parts of your body. And as Larissa asked, is it good for your eyes? As I said, what's good for your heart is good for your eyes. And we know exercising is good for your heart. It's going to improve blood flow. It's going to improve glucose tolerance. You'll feel better. You'll think better. And you should eventually see better if you're doing all the things that you should be doing to control your diabetes.
Thank you. So I'm going to give you a quick little break while I deal with some of our FBC business, and then we're going to open it up for questions from the audience, which I'm sure everybody's eager to get to. But before I get there, I just want to let the audience know about two things. The first is that we actually have a survey that we have just opened, which is about living with diabetic retinopathy or diabetic macular edema. And we would really love to hear from you about this. So this is a survey that is trying to understand what is the experience of somebody who is living with these types of vision loss. And the information from these surveys really helps us explain to policymakers what it's like to live with vision loss, and crucially, why new treatments need to become available in Canada and accessible to all Canadians. So we'd really appreciate if you either have diabetic retinopathy, diabetic macular edema, or if you know somebody who does, please tell them about it. Morgan will send out a link to the survey after this webinar, and if you fill it out, you'll get entered into a draw to win one of 3 $100 gift cards. So hopefully there's a little potential incentive to hear your voice, and we really appreciate that. It would really help us out. And then secondly, and also very importantly, I just want to take this opportunity to thank our supporters and monthly donors who have joined us on this call. We really couldn't do what we do without your generous support. As everybody knows, research is very expensive and it's a really long-term investment, but the results are life-changing. So if anyone wants to join our community of course supporters, you can make a big difference by joining our monthly giving program. So for as little as $1 a day or $10 a month, your gift can make a really big impact for people living with vision loss. And why monthly giving? There are two main reasons. The first is that it provides a really reliable and consistent source of funding for us. So it ensures that Fighting Blindness Canada can make long-term investments into research. And the second reason, and also a really important reason, is that it reduces our administrative costs so that more of the money that you are goes directly to vision research. So please consider joining today. You can visit our website at fightingblindness.ca, or you can contact us at 1-800-461-3331. So I just want to sort of ask Dr. Choudhry this, so you know firsthand what this sort of support means to us, because not only are you a clinician, but you're a member of Fighting Blindness Canada's board of directors. So I was wondering if you could just take a moment to tell us why you think it's so important to fund vision research.
Sure, and I'll put my research hat on because I do a lot of clinical research, as do a number of doctors in Ontario and City in the space of retinal research. And I think, it's a beautiful time in research because everything is booming very quickly. Science is moving very fast. And when it comes to vision loss, there's a lot of technology and a lot of innovation that's happening. And I think research is exploding at a very rapid rate. If as a diabetic, counselor and physician, counsel people on diabetes, I can tell you that one of the major thrusts around the world is to detect this disease earlier. And many of us have probably heard about artificial intelligence. Myself and others around the world are doing research in this space to help detect diabetes earlier, and also not only detect diabetes earlier, but allow patients to have access to these screening technologies at home. There are devices that are being developed that allow you to monitor your own diabetes at home through your cell phone and through other secondary devices. We're developing research therapeutics to treat diabetic macular edema so that the therapeutics last longer, they're less invasive. New surgical techniques and tools have been developed. All of this relies on research and research funding. And, obviously, as we all are touched by all these different conditions, we're all touched by the pandemic right now. We're all touched by COVID-19. I have people in my family that have diabetes. I'm sure we all know at least one person. This is a very important area of medicine. It's a very important area in eye care. The top 4 conditions in Canada where there's vision loss, diabetes is on the list of number 1 and 4. 1 in 3 Canadians has diabetes or prediabetes. 500,000 Canadians have diagnosed diabetic retinopathy. I mean, all of our fellow Canadians and all of our fellow people around the world are touched by this. And so it is imperative, and we are making big, big strides. And that happens synergistically with research funding, with innovation, with an open-mindedness, with presenting ideas, and most importantly, with supportive organizations like the Foundation, who's been instrumental in helping to get therapeutic drugs for inherited retinal diseases to Canada, which many of you may have heard of, and also just in general of trying to put Canadian research on the map. Many drug companies sometimes overlook Canada as a place to bring their research clinical trials, and patients ask me all the time and my colleagues, are there any trials I can enroll in? Are there any studies I can be in? And we want to be able to answer a resounding yes. The way to do that is to lean on the Foundation, work as a group, and help bring research funding to Canada and bring trials here.
Thank you. Thank you for telling us a little bit about your research as well. It's really interesting. Yeah, Morgan, I will turn back over to you now.
All right, great. Thank you so much. All right, so please feel free to put your questions in the Q&A or the chat. And you can also email me, again, education@fightingblindness.ca. I did pop that in the chat to make it a little bit easier. So I have a bunch of questions that have come in. Let's start here. So Warren sent me an email, and he was talking about how he was recently hospitalized because his sugar was very high. And around the same time, he'd noticed some changes to his vision, especially difficulty reading. So since then, he's made a lot of the lifestyle changes you talked about, eating a balanced diet, getting exercise, and thankfully his sugar has started to come down, which is great. But unfortunately, his vision has not really improved at all. And so Warren was wondering what he can do to prevent further vision loss, and is this normal that it's not going away even though his sugar has gone down?
Yeah, so I think, one of the things that we do see sometimes is that despite your improved sugar control, issues related to your diabetic retinopathy may not improve or may not change. It does happen. We're sort of playing catch up. There's been years of damage happening, and now that we're back in tune with our sugars, our vision isn't catching up fast enough. I think in this gentleman's case, it's not clear what the underlying cause of his vision loss is, whether it's diabetes or not. I think the first thing that I would suggest, again, is really to connect with either the family doctor or his eye care provider to have an eye exam so that a correct diagnosis can be made, because he may not have diabetic retinopathy at the moment that's impairing his vision. So I think that's the angle that I would take with this particular situation if I were in that situation.
Absolutely. So important to find out exactly what the cause is.
Yeah, it's important to know what's going on. So otherwise, it's very anxiety provoking.
Okay, and then we have a question from Atfe, who's asking, does hypoglycemia have any risk for vision? So hyper and hypoglycemia makes us feel bad. We don't feel good when we're out of equilibrium, when we're out of balance. And so what can happen with the eyes when the sugar is changing constantly and swinging all over the place? The vision does change. And as you know, we have a lens inside our eye, which we talked about earlier, which can become a cataract. The lens itself swells and shrinks in response to its environment. And that environment is affected by glucose. So yes, hyper and hypoglycemia both can cause your vision to blur, which is another reason really to try to have more of a steady state or a steady equilibrium of blood sugar, which obviously hopefully your family doctor could work with you or diabetologist could work with you to help control. And Devin asks, what are your thoughts on intermittent fasting to assist with controlling blood sugar levels? For example, 16 hours of fasting and 8 hours of eating daily as a standard typical pattern. Yeah, that's a great question. I think it's best suited for a nutritionist or a diabetic nutrition specialist. I don't know enough about the diabetic diet recommendations to answer that question properly, but I would refer you to
the Canadian Diabetes Association or the FFB and get directed to a nutritionist who could possibly answer that question better, and how it would connect with your vision as you change your diet specifically to that diabetic regimen.
Absolutely. Donalda asks, I'm about to have a cataract removed. Will it increase the risk of retinal adenopathy? I'm saying that right, or even macular degeneration?
So that's actually been studied. So I'll try to rephrase the question in a way that I'll answer. So cataract surgery is a common surgery that happens. Many of us will have a cataract surgery, if not all of us, throughout the course of our life. And the risk of cataract surgery exacerbating or inducing macular degeneration has been studied, and that is not the case, meaning you can have a cataract surgery and not cause or worsen macular degeneration, a different disease than what we're talking about today. And diabetic retinopathy has also been studied in that capacity. And some work from some of our colleagues, Dr. Michael Brent and others, have done some work in that area. And what we do know is that cataract surgery can in some cases make diabetic macular edema worse immediately in the time surrounding the surgery. So if somebody has macular edema and they're going in for cataract surgery, usually their specialist that's managing the macular edema will plan to treat them so that there's not a significant worsening just after surgery to keep things at bay. So that's what happens with macular edema and cataract surgery.
Okay, I have another question here from Diane. It's very specific, so let me read this to you. I don't know if I understand it, but I'm sure you will. So she says, my husband, who is a type 1 diabetic for 42 years now, was on a pump and a CGMS, but previously very poorly managed on 2 shots a day of NPH and no BG monitor. Has been treated for a bleed in his macula for the last several years, since about 2014. Is this degeneration of the macula related to type 1 diabetes and blood glucose levels that even a pump and CGMS are very hard to keep in control?
So it's hard to answer that question because there are many reasons to have a bleed in the retina that may or may not be related to diabetic retinopathy. You mentioned one of them earlier, Morgan, which is macular degeneration. That's a condition that we treat pretty much chronically for such types of bleeds. So I can't say specifically by just hearing the term bleed in the retina, that's not specific enough. So that's a good question to ask their treating provider. But if you are being aggressive with your diabetic retinopathy, your diabetic management and your sugar and your insulin, it can only work to your advantage in treating bleeds related to diabetic retinopathy.
Absolutely. And now, before you had mentioned that sort of the first line of treatment when things get sort of out of control in terms of bleeding is injections in the eye. Are there different types of injections, different kinds of drugs that can be used?
Yeah, so there are different types of drugs. As I said, this all speaks to the research part. We can only have options if we do research. So we're fortunate enough that in 2020 we have 5 options for these types of medications. They're under a class of medications which are called anti-VEGF, anti-VEGF. The VEGF stands for vascular endothelial growth factor. So the eye is producing a hormone called vascular endothelial growth factor as a result of being starved of oxygen and nutrition. And the anti-VEGF is, as you would expect, it's an antibody that prevents that hormone from inducing more bleeding. And there are different drugs that are in that class, and there's now 5 of them. And if you are getting treated or about to get treated, it's great to ask your provider about the medicine and make sure you understand their choice. But the good thing in Canada is that we do have choice, and that our research endeavors around the world have led us to the point where we have options and they can be tailored to your situation.
Thank you. So Janice has said that she's had 2 vitrectomy surgeries in her left eye within the last couple of months. In the first situation, she had a gas bubble inserted, but then her retina unfortunately detached. So she's had a second one just in September, and she has a silicone oil bubble inserted. So she's just asking, are there side effects from this silicone oil bubble? Her vision right now is very blurry, and she's wondering if the vision would clear up after this silicone oil would be removed.
Yeah, so that's a challenging situation, and those of us like myself and others who operate on these types of more advanced forms of diabetic retinopathy do encounter challenges like this. So first, I want to reassure her that, you know, these types of hiccups that come along through treating this disease are common, and don't be discouraged, because again, it's a battle. It's a battle of your provider and you versus the disease. And everyone's intentions are there to beat the disease back. So silicone oil is a longer acting, what we call tamponade. Tamponade basically means a device which is pushing the retina back on. And so silicone oil can be left in the eye for 3 months or for the rest of your life if that's what's determined. And it can cause some blurring of the vision because, again, looking at the optics of the eye, you have something sitting in the way of the otherwise clear path. So sure, it would be normal to have some blurring of the vision while you have the silicone oil in the eye. Things to watch out for obviously are any pain in the eye, which could be a sign of increasing pressure in the eye, but I imagine your provider is watching the pressure closely. So, you know, these are the two big things. Sometimes if you have oil in the eye and you have your natural lenses there, it can also cause a cataract. Again, that's reversible. So, you know, usually when we elect to put something like oil in the eye, it's because that's the best option for the state of the disease. So I would speak to your provider more about some of the things that we've talked about here, but that sounds probably as comprehensive as I can be without knowing more information about the case.
I know this is difficult because people do send in very specific details, and it's hard when you're not treating them and know the whole situation for sure. Oh, this is a good question. So will you always, if you have diabetic retinopathy in one eye, are you always going to get it in the other eye, or can you just have it in one?
So I'd say, like, you know, 9.99 times out of 10, it's in both eyes. The reason is diabetes is a disease that affects the whole body. So it's like, it would be the equivalent of saying diabetes will affect my one side of my brain, but not the other. There's no privileged area. So because it affects blood vessels indiscriminately, then all blood vessels everywhere will be affected. There are rare instances where it's preferentially worse in one eye than the other, and without confusing the audience, I think the best take-home message really here is that diabetes affects everything, everywhere, usually equally.
Okay, so if I'm diagnosed with a diabetic retinopathy, do I have to stop driving?
So that really depends on what the vision is, right? So you don't have to have diabetic retinopathy to be told you can't drive, right? There are other causes of your vision impairment that could induce you to not meet the criteria to drive. Just having diabetic retinopathy alone, that's not affecting your vision to a certain degree, does not result in you losing your license or anything like that. There are specific vision criteria and visual field criteria that the Ministry of Transportation has set out. And that's a great question to ask your provider based on the actual data, how well you see, what your visual field is, to answer that question more specifically. But generally speaking, if I was given a rubber stamp tomorrow of diabetic retinopathy and I had 20/20 vision, I'm not required to stop driving.
That's great. Let's see here. Can you recommend a vitamin or mineral program for me that might be helpful, or are vitamin supplements specific to each person?
So I think it's a little bit of both. You know, I think everything is specific to all of us. You know, some of us can take a regular multivitamin and feel fine, and others might get sick from it. So that makes the vitamin story a little bit very much personalized. What I can speak to is the types of molecules that the retina requires when you have regular aging or even diabetic retinopathy. We know that the center of the retina, as I mentioned earlier, the bullseye of the dartboard, the macula, is rich in molecules such as lutein. Some of us have probably heard that before, that term lutein. And there's a couple of other molecules, zeaxanthine, mesozeaxanthine. They're kind of a mouthful, but these molecules are naturally part of your retina now. And as we age and or when we have retinal diseases, the concentration of those molecules does go down. So the best answer for, which supplement should I take and how much should I take, it should really be a discussion with your eye care provider. But the 10,000 foot answer from above is really that, yes, there are some nutritional elements of your vision health that you could take an effort to correct that could help give you a little bit of a bump to help make sure that you keep healthy as much as possible and you age as well as possible.
Absolutely. Let's see, more here. What are some of the most exciting new treatments or research that's coming in the next, say, 2 to 5 years?
That's a big question. There's so many things to talk about. I'll probably focus, I think, on a couple just right now as it pertains to diabetes. We have one of our greatest burdens amongst patients that have diabetic macular edema is the fact that they come in very frequently for these injections to the eye that I mentioned earlier. So the big effort right now is to make drugs that either last longer, to reduce their injections and visits to the office, especially now that we have COVID. We want to be mindful and strategic about coming in, and also us as providers hosting patients here in any facility. And then the second aspect of developing products and devices is how can we make existing drugs last longer? So an exciting area right now is, and I think I talked about this in the past at another FBC event, is really looking at a device that can be implanted into the eye, and it functions like a gas tank. It's called a port delivery system, or PDS. And this port delivery system is effectively like a little reservoir that sits in your eye, and it can be topped up every 6 months, and it slowly releases a drug, one of these anti-VEGF medicines, over 6 months, allowing you to have the treatment that you need, limiting your visits, and limiting in number of injections. So I think that that's one of the most exciting here and now, nearly around the corner type technologies or devices that we can, as people who treat diabetes or diabetic patients, could look forward to.
Absolutely. And I have another question here about, let me see if I can read this up. So this is from Kamal. And so I'm not sure if this is really necessarily related to diabetes, but it is about sort of new treatments coming up. So Kamal talks a lot about his surgeries. He's had vitrectomy and scleral buckle. He's done a cornea graft, and he's saying his visual acuity is only 20/400 plus, high astigmatism and macular degeneration as well. So he's just saying, is there anything that can be done except saying just leave it at status quo? And he's wondering if stem cell therapy is coming to Canada, and if it is, how soon it might come to Canada.
Yeah. So, there are a number of Canadians who have very challenging states of their disease. And as I mentioned earlier, as a provider and as a patient, we're all aligned in trying to battle the disease back together. It sounds like there's been a lot of surgical interventions and a lot of challenges with managing the disease, because the disease can sometimes really take over, and depending on what stage it's captured. One piece of advice, or one option to explore novel ways of managing your vision that you have now, would be to explore a vision rehab specialist or vision rehabilitation specialist, previously known as a low vision specialist. The foundation partners with somebody really great, who also I like, is Dr. Anna Jurcic. There are others out there, of course, many other good ones. But seeing a vision rehabilitation specialist can be helpful in this type of circumstance where surgical interventions have been done, and there is a sort of still a limitation in the vision to a reasonable degree. The vision rehabilitation specialist specializes in trying to maximize the healthy part of your retina or your vision to do as much of your day-to-day activities as possible. And that includes things like not only using magnifiers, but telescopic lenses, to other new and novel technologies, wearable devices, digital virtual reality devices. That the spectrum is very vast and growing and super exciting, much more than what we had 10, 15 years ago. So that's one arm of an approach to take. And the second, as you asked about stem cells, Stem cell work is being done in all aspects of medicine. I definitely do not know every single trial that's happening, but you can go to a good website that should have almost every important clinical trial listed online, and that website is www.clinicaltrials.gov. So that's a US website where global clinical trials are registered, and you can search whatever search terms you want. Stem cells and retinitis pigmentosa. You can search Leber's hereditary amaurosis. You can search diabetic retinopathy. And you'll find everything and anything that is being done on a large scale around the world registered at that site. So I would encourage you to take a look at that, and also not ignore the utility of a vision rehab specialist.
Absolutely. I think that's a really important. Oh, sorry, go ahead, Laura.
No, I was just going to jump in there and just add on to what Dr. Choudhry said, because that website's great. It's also, it can be a little bit complicated. So if you want any help with it, you can contact our health information line, which maybe Morgan was going to get you anyways. And she will send out information about that after this webinar.
I should add that, you know, the foundation is a valuable resource, and as a board member and, you know, a partner with FPC for a number of years now, you know, there's a significant commitment to helping patients navigate to trials, bring trials here, disseminate information, you know, relieve anxiety about being in the dark or being lost on the web. So definitely reach out to the foundation and exhaust our resources first. This is just another one I just threw out into the wind for you, but you know, I definitely direct my patients to the foundation, even and also to the clinical trials website. You know, there's a lot of things on the internet, and we want to make sure that we find things that are vetted by providers and by, you know, our educated population, to ensure that you get to where you want to go and you get the right information.
Absolutely. I think great minds think alike. We were all in the same wavelength there. So I think that's great. I mean, we do have a page on our website about diabetic retinopathy. As Larissa said, tomorrow I'll be sending an email out with everyone that will have the information on our health information officer, who can help you kind of navigate clinical trials or point you in the way of resources that might be helpful for you. So I think it's great that you're talking about like a vision rehab. Obviously there's CNIB, they have like independent living skills, orientation mobility, that kind of thing as well. Are there any other resources that you would point people to, even in around managing their diabetes, that might be helpful?
So I think, you know, one of the beauties of diabetes is that it's a very common condition. And why I say it's a beauty is because there's a lot of resources out there, a lot of opportunities out there. I think your family doctor is a great resource to find out about a diabetic nutritionist. I think nutrition gets really ignored. We get stuck in eating tablets, which, you know, it is necessary at times to take your medication and make sure that you're on the ball with that. But lifestyle is something that, you know, we can all control. I think engaging with, you know, someone to help you with exercise if you need it, nutrition if you need it, smoking cessation if that's an issue. I think these are all things that you don't need a prescription for, meaning, you know, we don't need to tell you to do that. I think it's something that you know internally that we should address it. And I think everything starts with what we eat. We are what we eat, right? So having multiple sodas every day, or eating badly, ignoring your health, living in stress, being neglectful towards your health, which all of us have been, you know, a victim of, I'd say, at one point or another. I think those are the easy, low-hanging fruit types of events that, or resources that we should seek. And the family doctor can be a very good resource to try to find a nutritionist or get a referral to someone like that, and a podiatrist.
Absolutely. So someone else asked in the chat, is there anything that can be done for a person who has gone blind from retinopathy?
So it depends on the extent of the disease state, right? So blind is a very generic term. You know, there's criteria for that, but, you know, if you've lost vision from diabetic retinopathy, depending on the nature and cause of that loss, there may or may not be something that can be done. If it's diabetic macular edema, obviously there's a treatment for that. If there was a retinal detachment, like we heard some cases tonight, you know, there is surgery for that. And then if you sort of have exhausted all options and you're still limited, then there's vision rehabilitation, obviously, where that's an option. And then we go into the out-of-the-box world, right, where what's coming up next is more exploratory. There is, you know, retinal gene therapy being looked at. There is transplantation being looked at. There has been the movement towards homogenization of computer technology with human tissue. So a few years ago, we had the birth of this mixture through a device called the Argus 2 device, which you may have heard of. But technology is working towards trying to give people vision as in any way possible that they can. So I would say not to lose hope. That's really what I would get to answer that question. If you've exhausted all the options, I would still remain hopeful because so much is still happening. I think we would never have thought that we would have AI in 2020 and we would be this far along, and it's exploding so quickly. I think, necessity, as we know, is the mother of invention, and now more than ever, we're seeing so much innovation because there's so much need. So stay hopeful, stay in touch with your eye care provider, speak to your healthcare provider team, be in touch with the foundation. If there's something new and innovative, the foundation will help direct you. And events like these are great to sort of get new ideas and bounce off questions.
Absolutely. So I have one more question. So this is the last call. If anyone has any questions, to get those into the Q&A or chat. So my last question here is related, kind of a COVID question, I think, off the topic of getting injections. So they're wondering how do you determine how often to have injections? Does it necessarily have to be every month? They're saying that sometimes their injections are further apart, and they wonder how that's determined.
Yeah, so that really speaks to the personalized nature of this condition. So the medicines themselves last a variable amount of time, and we see an upper limit ceiling of about 3 months with some of the drugs. So it really depends on the way we determine how frequently to see a patient, or with someone with diabetic macular edema, for example, is really dependent upon how quickly we can dry the retina and how long the retina stays dry before it gets wet again. And so one would ask, well, why is it getting wet again? Didn't you just treat me? So when we're treating the diabetic macular edema, we're treating the fluid and the leakage. The vessel damage is treated on its own, meaning your natural ability to heal, hopefully, is what is treating the blood vessels from staying broken and degenerated. In some cases, the vessels never recover, and there is a very long duration of treatment required. But in many cases, we are able to control it. So the way we determine how frequently to see you and treat you depends on how long your eye can stay dry before it gets wet again. For some people, that's 30 days. For the best people, or the luckiest people, I would say, or the most responsive treated people, it can be 3 months, 4 months, rarely even longer. So that's what makes this all individual. Diabetes will hit me different than it'll hit Larissa, different than it'll hit Morgan, and all of us will respond to therapy in our own unique way.
Absolutely. All right. Well, I think that's all for our questions. So thank you so much. And thank you, Dr. Choudhry, for joining us to talk about this important topic to kick off our Diabetes Awareness Month. And I meant to mention this at the beginning, but if you've been a Viewpoint watcher, Dr. Choudhry was our very first Viewpoint back in April, talking about COVID. It's kind of hard to imagine that was like 7 months ago, and here we still are. But thank you, everyone, for joining us. And I really do encourage you to go to our website and sign up for the other 2 webinars in this series. Again, November 9th with Diabetes Action Canada, talking about tele-ophthalmology program. And then I'm very excited for our November 24th panel. It's going to be all about living well with diabetes. We have Dr. David Wong will be joining us. We have an independent living skills specialist from CNIB who's going to talk about sort of adaptations that you can use to make sure you're controlling your blood sugar and living really well. We have a diabetes educator and a patient partner who will all be on that panel. It's going to be a really great discussion, so please sign up. Okay, and there will be a survey that pops up after you finish today. We'd love to hear from you, get your feedback on what you loved and what you think we could do better. We do look at that feedback and incorporate it when we design our next webinar series that will be coming in 2021. So please help us out there as well. All right, I look forward to connecting with you all at our next webinar. Stay safe and stay healthy. We'll see you then. Bye.
Thanks, everybody.